Hello everyone, welcome to Medverse. I am Biswanath and today we are going to discuss the favorite topic of medicos, that is ECG, okay, electrocardiography. Talking of ECG, we will not take a conventional physics approach which is given in all standard textbooks of ECG, right? We'll rather try a patient-centric approach and it will be systematic in a way. Okay, we have to check some things and I have to check the morphologies, we have to check some durations, we have to check some intervals, and we are done with, right? So we'll analyze each and every ECG with a systematic approach, right? Rather than discussing it in a haphazard manner. If you become a DM cardiologist, then it is like a cakewalk, right? You can just look and see, tell the diagnosis. But our approach is what a you can say layman will understand looking at the ECG. Not layman, but first year medico can easily do with this ECG module, right? This from starting of first year to final year to intensive and beyond, right? But it is structured in that way that even a first year medico, if he pays a certain amount of dedication and attention, can easily do with ECG, right? So talking of ECG, ECG is basically the graphical representation of the electrical activity of heart. Or in simple terms, it is the graphical representation of cardiac cycle. Is the graphical representation of the cardiac cycle in simple terms. Okay, so what ECG we commonly use is the 12 lead ECG. So the standard ECG is a 12 lead ECG, 12 lead ECG. Okay, it is a 12 lead ECG and the speed is 25 mm per second. 25 mm per second is the paper speed at which it is rolling, right? Don't go into technicalities, just try to understand, remember the facts. Okay, that's it. Don't use your brain too much, don't use your imagination, don't use your prerequisites too much. But the ECG you have to understand is a patient centric one rather than a clinical discussion. Okay, so I'm sure you must be understanding what I mean. Okay, starting off with, we have 12 lead ECG. So, what are these 12 leads? First, we have to discuss that thing. So, remember, ECG is basically a 3D view. Okay, I can't say view, but I can say study. The 3D study. We have some leads which will see at a axis and at a perpendicular to that axis. So, basically, what I mean is that we have to, if this is the heart, then we have to see at a transverse axis, we have to see at a vertical axis, right? So this is the thing. Starting off with, we can't really see that in 3D, but what I can make is that we have some six frontal leads. Okay, we have some six frontal leads and six horizontal leads, right? So six frontal and six horizontal. This lead placement is very very important because these leads are basically like cameras, which you are seeing the heart from different cameras, right? So this is the thing. Let's make a heart here. A very basic diagram. This is our heart. Let's consider this is our heart. Okay. The lead that is literally the vertical pillar type of thing, that is AVF. So straight down AVF. This is the lead. Okay. The lead perpendicular to that AVF is lead number one. The lead perpendicular to that AVF is lead number one. Okay. This is done. Remember, the heart has an axis, the heart has a base, the heart has an apex. So the axis that is passing along the axis of heart, the lead that is passing along the axis of heart is the lead number two. So it is the maximally aligned lead with the normal vector. So normal vector of heart is the heart direction. So this is the normal vector of heart, and the lead that is coinciding, that is seeing at the normal vector of heart, is the lead number two. So that's why you commonly use lead number two as your reference in most of the cases. Okay, so this is lead number two. Lead number two is a maximally aligned lead with the normal vector. Okay, this is clear. Okay, so this is a normal vector, this is the direction of the lead number two. Okay, let me write two here. This is done, and coming like this is the lead number 3. Lead number 3. Okay, this is done. And going in this direction between lead number 3 and lead number 1 is an AVL. This direction. This direction will be your AVL. AVL. Okay. This is the frontal leads. This I talked about frontal leads. This I talked about frontal leads. If this frontal leads is clear, we'll move ahead and we'll discuss about some horizontal leads or the chest leads or the precordial leads. Chest leads numbered from V1 to V6. Now, I can't really show you that placement, but what I can do is place the heart in that horizontal plane and place the cameras along with it. Okay? Don't use your brain too much, just try to understand. So now I place the heart like this in the horizontal plane. Okay, this is not the heart, this is something else. So this is the heart. Okay. We don't really want that heart. Okay. So this leads V1 to V6, how we place them. Let us place this V1, V2, V3, V4 in line. Okay. And V5 and V6 above it. V5 and V6. Okay. This is the thing. So now we have to name the leads. Okay. We have seen the placement of the leads. Now we have to name the leads along with the placement. Okay. So starting off with frontal lead, look at this. This one, this three leads, the third, the AVF, and the second lead. The third AVF and the second lead are called as, these are down, right? So remember, these are called as inferior leads. Inferior leads. These are called as inferior leads. These are called as inferior leads. And the normal electrical vector, or you can say the direction of lead number 2, is basically inferiolateral anterior. Okay, what I'm telling is that it is going inferiorly, it is going laterally, it is going anteriorly. It is going like this. Okay, if I'm looking, it is coming towards me laterally, down and laterally, and anteriorly even. Okay, so the normal vector or the lead number 2 is aligned in inferior, anterior, lateral, inferior, anterior, lateral. This is your normal direction. Okay. And which lead is maximally aligned with the normal electrical vector? This is again lead number 2. Okay. This is done. Okay. Now we will have some lateral leads now. We have seen the inferior leads. Now we'll see the lateral leads. Remember this AVL and lead number 1 along with this V6 and V5. These are called as this is not looking that pretty. Okay. These are called as lateral leads. Lateral leads. Inferior lead is done, lateral lead is done. Okay. This V1 and V2, this V1 and V2 are basically cameras to visualize the septum of the heart. So this V1 and V2, these are called as your septal leads. Septal leads. Okay. V3 and V4. This V3 and V4 are basically your anterior leads or the apical leads. Apical or anterior leads. Apical or anterior leads. Look at this again. I'm sure you understood what are the placements of the leads. Okay. Okay. So starting off with, now we'll discuss a concept which is called contiguous lead. So what we discussed totally now is basically the concept of contiguous leads. We have already discussed the concept of contiguous leads. Contiguous leads are, what is the term basically? Contiguous leads are leads which are representing a specific part of heart. Okay, like the septum of the heart. The septum of the heart, which two leads are basically visualizing the septum of the heart. The visualization of septum of the heart is done by V1 and V2. So V1 and V2 are contiguous leads. Which part, which the apex of the heart is basically visualized by which of the leads? Which of the cameras, I can say, in heart terms. Apical leads are basically V3 and V4. So V3 and V4 are basically contiguous leads. Likewise, AVL1, V6, V5 are all contiguous leads. 3, AVF and 2 are basically contiguous leads. Okay, understood. So that's all in today's session of graphical things. Okay, we saw from the graph. Okay, so starting off with again, the let's discuss about the standard ECG waveform. Then we can move forward, right? If you know the normal, then you can easily extrapolate the abnormal things. So starting off with the normal ECG waveform. The normal ECG waveform. So if I talk about the normal ECG waveform, what are the things? You all draw like this. This is your P wave. This is your P wave. Again, an isoelectric line. Remember, the lines that are not showing any dip or any fall are called as isoelectric lines. These isoelectric lines are electrically neutral. These waves are basically deflections. Whenever there is a potential difference, there is a deflection. There is a flow of current, right? So this flow of current are basically what are producing depressions, elevations or depressions. Okay. If a depression, if you can say something, if the current is going in line with the vector, if the current is going in line with the vector, it's positive deflection. If the current is going in negative direction of the vector, it is a negative deflection. So you placed a lead somewhere. If it is going towards the lead, it's a positive deflection. If it is going away from the lead, it is a negative deflection. So now you understood what are positive and what are negative deflections. If you understand this, then it is very, very, very easy. Okay, whenever I say something, then you can easily extrapolate the vectors and do it. It's simple maths, right? P, the P wave. There is a dip here. This is a Q wave. You must be wondering why I wrote a small q. Because whenever there is a large q, there is a large dip. Small q is the normal one. You must be taught from many teachers that they always write capital Q. Capital Q is just a blunder. You have to write the small q in normal SCC. Q wave is there. It again moves up and a steep slope. That is an R wave. R wave. Okay. Again dips down. S wave. Okay. Then it comes to isoelectric line. Just a minute. It's R wave and S wave. Isoelectric line. Okay. Then you get the T wave. This is a normal waveform, very, very, very rough. Okay, very rough. So P wave, remember it corresponds, just a minute, let's get my pages. P wave, remember it corresponds to atrial depolarization. Okay, whenever the atrial, you know the conducting pathway, right? There is a SA node here, there is a AV node here, there are some bundles, right? Some internodal fibers. This internodal fibers are basically thorals, Wenckebachs. The names are there, but that's not important. What's important is that the impulse originates from the SA node in the normal heart, and the impulse that is originating from SA node is a sinus rhythm. So it is traveling towards the AV node. From the AV node goes to the AV bundle. Then it separates from the right bundle of his and left bundle of his, and then it moves down like this in a spiral fashion. Okay, you can say spiral fashion, but is going through the ventricles and the wall of the ventricles. No, ventricles depolarize due to some short fibers originating from that. That fibers are called as Purkinje fibers. Purkinje fibers. Okay. I'm sure you must be have read all the normal pathway. Okay. We'll see abnormality. Don't worry. First, let's finish the normals. Right. So P wave is basically when the impulse originates and there's a contraction. There's a contraction of the atria that is called as atrial depolarization. So P wave corresponds to atrial depolarization. Okay. QRS complex is basically a ventricular depolarization. QRS is not a wave. P is just a wave. We can't say P complex. P is just a wave. But QRS is basically a complex sort of thing, right? It is going down and up and down, right? So QRS is basically ventricular depolarization. Ventricular depolarization. Okay. And T wave is basically ventricle repolarization. So ventricular repolarization. These are your waves. In ECG, very important thing, you have to know the difference between a wave, a complex, a segment, and an interval. A wave is basically a deflection, positive, negative, nothing like that. Complex is a combination of deflections, negative, positive, negative, isoelectric, everything. Combination. QRS is a complex. QRS is a complex. Interval is basically specified time, specified interval. Interval means is endpoint, starting point is there, end point is there. Like I say PR interval. So starting and end point. So P and R. Starting of P wave to the R wave. The PR interval. Whenever I say segment, there is a no starting point or end point. It is just a line. Okay, you must be have taught the concept of line and a line segment. Whenever you wrote segment, you wrote like this. You put dots A to B, line segment. Whenever you say line, then you draw like this. There's no specific. So line is the segment, right? Right. So interval here. This concept is of maths. Interval here has a point, starting point and end point. But this segment has no particular end points and start points. Okay, understood? Okay. Let's move ahead. So understood? That's clear. Okay. So now that was a mathematics concept. Don't go into that. But what I am telling is that now let's talk about intervals, right? So intervals I told you is a definite time interval. So I am telling PR segment. So starting of P, the R wave is basically the PR segment. PR segment. PR segment is a baseline, that is isoelectric line. So in PR segment, what is happening is that the impulse is traveling from your atria to ventricles. That is an isoelectric point. Isoelectric point is that there is no deflection, right? Because current is traveling only. Okay, nothing is there. Nothing is depolarized or repolarized, nothing. So it is just a isoelectric, it's a baseline. Okay. Now we have something called ST segment. ST segment here the changes are recorded at the onset of ST segment. Okay, this onset of ST segment is called as a J point. J point. So J point is basically the onset of ST segment. Okay, and we have something called QT interval. QT interval. QT interval is at the beginning of Q to the end of T. QT interval. This QT intervals, what is the significance? The significance is that it is the entire ventricular events, the entire duration of ventricular events comprising of ventricular systole to ventricular diastole, right? So ventricular repolarization to depolarization is basically what is there in the QT interval. So QT interval is basically the entire ventricular events, depolarization as well as repolarization. Okay, the entire ventricular events is represented in QT term. Okay, now we have this Q. What is this Q? Q is basically is called as physiological Q because it is the first negative deflection and it is physiological. But whenever I write Q, I'm sure you must be you must be writing this Q starting from your first year, or you can say starting from class 12, class 11, whenever you have read ECG first time. You must be writing P QRS complex T wave like this. Okay, but this Q is wrong. This Q is a pathological Q. Pathological. And if this is a pathological Q, it is amplitude is more than this physiological Q is basically less than 1 mm in amplitude, but this pathological Q is basically this time. But this pathological Q when the amplitude is more than 1 mm, okay, and it representing area of infarction. It represents area of infarct. Okay, but infarct is also called as the because there is a negative deflection, a high negative deflection. If there is a high negative deflection, what I mean is that there is a electrical hole in heart. There is a electrical hole in heart. Okay, so this electrical hole in heart is basically representing, or you can say, is giving rise to this capital Q. Capital Q is the pathological Q. Okay, and another thing which I want you to remember in basics is the lead AVR. What is special in this lead AVR? Because in lead AVR, the ECG waves are completely reverse. In AVR, basically, the P wave is like this. Okay, the QRS T wave is like this. This is the normal wave in AVR. Okay, AVR is the reverse one. Okay, this is the thing. And if you want to know if it is if you want to know if the EC is valid or not, if the EC is valid or not. So to confirm validity of ECG, basically what is happening is that in ECG room, many things happen. Whenever a person is undergoing ECG, then you can say the person may strike the hand. This person may the ECG lead may be wrongly placed. The technician may be you can say incapable or something like that. Okay, many things can happen and many possibilities are there. This is India. So to confirm the validity if a ECG is correct or not, we have to confirm the validity. How to confirm the validity is basically an inverted P wave. This inverted P wave is basically confirming the validity that the ECG machine is correct and if your diagnosis is wrong. Okay, not a wrong diagnosis, you can gives the right diagnosis as well. So this is basically inverted P wave confirms. Just a minute. Inverted P wave confirms that ECG is giving ECG machine is giving correct readings. Whenever this ECG machine gives an incorrect reading, there's a term given that is called artifact. So artifact is basically an abnormality in the recording of ECG. Okay, this is not an abnormality in the patient's heart. This can be easily confused with the patient's heart. Okay, you can find flutter waves, but this flutter wave may be due to some small negative vibrations or small vibrations of the patient. Okay, the patient is shivering, let's say. So you can get flutter waves. You never know that what can happen or what is the possibility. Okay, so this is the thing to rule out artifacts. This is very important. Okay, and AVR, remember that it is a mirror image of the standard ECG waveform. Okay, if there is an upright P wave in AVR, This is happening, and this is happening. Upright P wave in AVR. So, what can be the causes? The first and foremost cause you can write reverse lead placement. So, incorrect or reverse lead placement. So, it is giving an artifact. Or there is another thing that the heart is even wrong. Okay, so this is a confirmatory finding, but you can't really, you can say, rule out that ECG machine is completely correct. There's a very rare possibility, but this is a possibility that the heart is itself in the right side. The heart itself is in the right side. That is the condition of dextrocardia and dextrocardia. So this dextrocardia can be a rare possibility. Okay, the most important is the incorrect lead placement, but we can't, you can say, rule out dextrocardia. Okay, so that was the thing. So with this, we completed the basics of ECG. This is a very general discussion. I'm sure you must have read this part in most of the things. In the next lecture onwards, we'll try to go into the crux of the matter. We'll try to decode and shatter the ECG in complete detail. Okay, so that's all in today's lecture. Thank you and have a nice day. It's night to good night.